Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello everyone, welcome back to Cardiovascular Matters. We continue our segment on men's health, and in particular cardiovascular disease in men. It's the number one cause of death. One of the leading contributors to that is high blood pressure. And today we wanted to get with Dr. Walker to discuss what he does with patients when they come in and they're found to have high blood pressure. Dr. Walker?
Sure. So let's talk about what blood pressure is.
Okay.
So we usually give blood pressure out in two numbers. Sometimes we use three numbers, but the average person hears of two numbers in a blood pressure. The higher number, the first number, is the pressure within our arteries when the heart is beating or squeezing. The lower pressure is the pressure in the artery when the heart is relaxed. It's just maintained in that vessel because there's pressure in our arteries throughout the entire cycle, but the heart is only beating when it's squeezing, and the heart as a pump needs its chance to relax. Mm-hmm. So we typically have different cutoffs based on age and sex for normal blood pressure, but we know that as blood pressure becomes elevated, we have greater risks of cardiovascular problems, greater risk of stroke, greater risk of heart attack, greater risk of kidney dysfunction, greater risk of heart failure because the heart muscle gets thicker over time. It doesn't get as good a blood supply because the blood supply to the heart itself is from the outside to the inside. And as it gets thicker and is squeezing harder, the blood supply is somewhat diminished. As the heart gets stiff, it doesn't fill as well. So all of these things occur with blood pressure being elevated. It's very important to not have high blood pressure. Now, the first question I'm often asked is, what's the best blood pressure? And I tell people it appears the best blood pressure is the lowest the blood pressure can be without symptoms.
There you go.
Okay, there are many, particularly young women whose blood pressures are in the 80s or even 70s who may be completely asymptomatic. And that is not pathological if they're feeling good. I mean, obviously, if they're passing out with that, then
Right.
It is pathological. But we want blood pressure low if it doesn't have symptoms. Now, if, of course, one is weak or is intolerant, then we don't want it at that levels. And so the first thing I do when I'm evaluating someone with high blood pressure is to try to figure out why is their blood pressure elevated. And historically, we've divided blood pressure into two classes. Primary, which means we can't figure out the cause. We're not smart enough at this point in time. There must be a cause, but we don't know it. Or secondary, where we understand certain things can cause high blood pressure. So all too often, patients go in and they have high blood pressure, and the knee jerk is, okay, let's just put you on a medicine. Well, we usually have to use a medicine, but it really is important to understand if it's primary or secondary because there are other implications. Now, in young people who have high blood pressure, often we're measuring blood pressure in our arms. Typically, that's where we measure it. Mm-hmm. Well, there is a congenital abnormality called coarctation of the aorta. Big word, but it means the aorta is pinched right in the area, right after the great vessel that comes off to our left arm, the subclavian artery. Now, this occurs at a level there, and it's a birth defect. It's a congenital disorder. And this is typically associated with a bicuspid or two-cuspid aortic valve instead of three, and severe high blood pressure as we measure it in the arms. And because the aorta itself is blocked at that level, often these people have pain in the legs when they walk, but not always. I remember one of my patients early on was a boy I went to high school with, and he was quite a track star. He came in and his blood pressure was sky high, and I measured pressure in his arms, and it was sky high, and so I measured it in his legs, and it was very low. Well, your pressure in your arms and legs should be the same.
Right.
And if it's not, it means there's some obstruction in the vessels. And he had coarctation of the aorta. Now, picking this up was important. It gave me the clue of what we had to do, but it was more important than just that. Because as I listened then to his heart, I could hear heart murmur. He had aortic stenosis because this valve only had 2, not 3 cusps. And that brought us to the point of, in the future, also we had to replace his heart valve. Okay. Very important to know. Mm-hmm. He also was having headaches. This is associated with aneurysms in the brain. And so a CT disclosed that. We were able to treat that. He's had a pretty normal life at that point after treating the coarctation with a balloon and dealing with these other problems. So that's one cause. We want to also check out the kidneys. And that's really as simple to start with as a blood test to see, is this person spilling protein in the urine? Or if pressure is really sky high, we might wish to do an ultrasound of the kidneys to see, are the kidneys shrunken? Are there cysts in the kidneys? Is the blood supply to the kidneys okay? Because if the kidneys do not sense that they're getting enough blood supply, they send out proteins that raise blood pressure because it said, gee whiz, mine isn't high enough. So one makes aldosterone and renin and things which cause fluid and salt retention and causes our blood pressure to go up. Now, the treatment for that, if it's a blocked kidney artery, is you fix the blocked kidney artery. You balloon and or stent it based upon whether it's atherosclerotic disease or what we call fibromuscular dysplasia, more common in women than men, the fibromuscular dysplasia. Atherosclerosis more common in patients as they get older. But that's another cause of blood pressure being high. In older patients, if the aorta itself is obstructed, not from coarctation, but from atherosclerosis, because blood is going preferentially to the upper body and not the lower body, pressure will be elevated in that circumstance. And keep in mind, as pressure is elevated, a lot of things are happening. It's causing injury to our blood vessels, and the blood vessels are more likely to develop atherosclerosis. It's making the heart strain. The heart is having to work out as a muscle harder against high pressure, so the heart's getting thicker all of the time, and that in and of itself stops the heart from being able to relax as effectively. Just as it would be harder to fill a thicker balloon made of thicker plastic, it's much harder to fill a thick heart, and that pressure backs up. That would be a secondary cause. Also, there are cases where people may be having hormones that are made that can raise blood pressure. One of those is a problem we call pheochromocytoma. And typically with that, people have hot flashes and other problems, but simple blood tests and urine samples can help us to detect those. Some people make too much cortisone hormones, and we call that Cushing's syndrome. And these patients can also have higher blood pressure because the volume is increased. So there are many reasons why our blood pressure may be up, and if there is a correctable reason, our first treatment should be to correct a problem that we know we can correct. But as I've mentioned before, more blood pressure is essential. We have not yet figured out the cause in essential blood pressure. We know that it's more likely to occur in certain families. We know that certain races have higher likelihood of developing high blood pressure. We know that certain customs lead to this, eating more salt and other things. There are many factors with essential hypertension, but that's the subject of a different talk. First thing is, if we go in with blood pressure, it's not okay just to say, let's start a medicine, okay? First thing is to see why. Now, when would I, at the same time, start a medicine even before I have that answer of why? If the blood pressure is so high that I feel it's malignant hypertension and it could cause a major problem immediately. And in that case, we would want to use medicines that would not interfere if it were a form of secondary hypertension where there is a cause. we would want to use a given medicine that would lower blood pressure but without interfering with those other things if indeed they had caused. In malignant hypertension, often patients can come in, blood pressure can be really sky high. In fact, it can be at a point where the patients are near comatose. They can be severely obtunded because of the pressure in the brain. And in those cases, it's very important to lower blood pressure. And typically in that group of patients, we would call that a hypertensive crisis, and we would admit that patient to bring the blood pressure down a little quicker than we would typically try to bring it down if they had no symptoms. And we'd want to watch these patients very carefully to make sure that nothing bad could happen at that point.
So when you have a patient that presents, and let's say they're symptomatic, and you take their blood pressure, and falls in the realm of crisis, you said you would admit them to the hospital, and at that point, I mean, I'm assuming you get on a pretty aggressive path.
Yes, not just for the high blood pressure, though, Terry, but typically high blood pressure associated with other findings. Findings like pressure may be increased in the brain. That person may be having difficulty seeing as well, or the vision may be a little bit worse. Oh, wow. That person may be somewhat obtunded already, and giving us a clue that maybe something's going on in the brain. And we would immediately get certain blood tests, of course, that would give us a clue to make sure there's not kidney failure going on right at that moment. Mm-hmm. But if the patient has these clinical signs, and we typically put them in at certain levels of blood pressure, we should consider that. Blood pressure's in the range up well above 200. Yeah. We should work on. Following Katrina, we had many people that had evacuated New Orleans that came here to a makeshift shelter, and they did not have medicines, and a lot of the local medicines had been taken from the pharmacies to bring for others, for other patients. And unfortunately, a lot of the evacuees had come to our town, and so we actually went out and got medicines and donated them to these patients, because we had many patients present with blood pressures well above 250, and one that I recall had a blood pressure approaching 300. And of course, these patients weren't feeling really well at all, right, as you might imagine. And we were able to control those issues. But these crises can occur, especially in longstanding hypertensive patients who run out of their medicines. And in today's world, in controlling blood pressure, we have many medicines. And typically, as we put patients on the first 3 classes of medicines, most people can tolerate the majority of those first 3 classes. But once we get beyond those first 3 classes, typically there are a lot of side effects, and there's future hope. We'll talk about these in subsequent talks. But there's a new process called, a new treatment called renal denervation, which can really dramatically lower blood pressure. It's not a medicine per se, but it's a treatment that can lower this. But for this point, first thing to make a point of is if someone comes in hypertensive, we want to figure out, is this essential or not caused by something that we can definitely find, or is it secondary? Mm-hmm. If it's secondary due to something else that we can treat, then the treatment becomes treat the thing causing the blood pressure in the first place. That's like anything in medicine. We want to always get to the cause if we can. Unfortunately, much of hypertension, we cannot identify the cause.
Right. Yeah, I'm just curious. I mean, this is a real simple question, but it's the first thing you hear about. And I was out to dinner with a cardiovascular surgeon one time, and he was putting so much salt on this steak we were getting ready to eat. And I asked him, I said, I read a study that said salt contributes to high blood pressure. And he said he read a study that said high blood pressure is better than no blood pressure. He was making a joke. I remember it to this day. But people are really, you got to have a certain amount of sodium in your diet to live. But where does that come into play in terms of high blood pressure? Because I see a lot of my friends, they're very focused on that.
Yeah, well, sure. Salt does make us retain more fluid. Mm-hmm. That's how salt typically raises blood pressure in us. And so it does increase that risk. And we know that societies with higher intake of salt are more apt or more apt to have hypertension. Now, to be fair, when I say salt, we're speaking about sodium chloride. Magnesium chloride is a salt, but it lowers blood pressure. If someone takes in magnesium. So, but table salt is what we're speaking about, and that is sodium chloride. And the question is, how does it affect a person with normal blood pressure who's otherwise healthy? And there's a lot of debate that is there. There are some people who say you should never eat it. It's a absolute poison, and others who say, not necessarily so. And I probably fall in that second category. I think, though, that certainly if one has severe high blood pressure that's hard to control, limiting salt can help a lot.
Excellent. Well, Dr. Walker, thanks once again. I mean, this was a big topic, and I think you've definitely boiled it down and made it where we can all understand. In the coming weeks, we're going to be talking about some of those medications you talked about concerning high blood pressure, so that people can make sure that they're seeing their cardiologist or doctor, and that they get control of their blood pressure. I mean, that's a critical aspect of their health. So again, thanks everybody for listening to this week's Cardiovascular Matters. Look forward to seeing you in the future. Thank you very much.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.